Thank you very much. Thank you and good morning to such an august audience. And Dr. Rasik Shah, thank you for very kind words and the invitation that you provided and for being my teacher in my days as a pediatric surgeon. Um, I have had the pleasure of serving as the division chief in critical care at Lebanon and currently serve both as the medical director of ECMO and critical care medicine. In addition to that, there have been some other achievements as such. My interest is in artificial intelligence, machine learning, in the use of ECMO and in sepsis. But the topic that I was assigned today by Dr. Shah was to talk on ECMO for congenital diaphragmatic hernia. And we are going to try and look through some of the questions about why, when, on whom do we actually offer ECMO for CDH, and how do we go about doing something of this sort. I have just a few disclosures. None of these are related to the presentation as such, and there will not be any off-label use of drugs that will be mentioned in this case. So this is something that Dr. Rasik Shah probably recognizes, maybe from a long time ago. This is where he had done his training, and as you will notice, Dr. Shah, the architecture of the institution has changed a little bit. We are a 265-bed children's hospital with a 41-bed pediatric ICU and a large NICU. All ECMOs for NICU are done in the pediatric ICU, and which is why one of the reasons we are involved with CDH management. In addition to this, we are a referral center for some of the other programs like cardiac neurosurgery, ECMO, and some of the other things. Our association is also with St. Jude Children's Hospital, which is a freestanding cancer hospital, and that is one of our referral centers as well. But coming to the case at hand, what we are going to talk today is more about ECMO and in CDH. Now we're going to look a little bit into examining the cardiorespiratory pathophysiology of CDH. We'll look at some of the standard clinical practice guidelines, which most of you are aware of, pre and postnatal risk factors, indications and contraindications of ECMO. How do we go about doing ECMO in these patients, weaning them off ECMO, and what are our results so that we can basically have a conversation about this. This is a familiar diagram to all of you, what a normal diaphragm looks like. On the right side, if the diaphragm is absent, that leads to the right-sided diaphragmatic hernia. And on the other side, you have the foramen of Bachtelek, which leads to the left-sided hernias. CDHs are a result of failure of cell migration during the diaphragm development. And 1 in 2,500 live births are associated with CDH. Some people say 1 in 3,000, but in the United States it's close to 1 in 2,500. 80% of these are left-sided CDHs. And even in the United States or in many of the developed countries, you will still find that there are some cases that get missed, either because of poor antenatal diagnosis or lack of antenatal diagnosis, which may sound surprising, but not to us. CDHs are also associated with significant anomalies and syndromic conditions. It is a surgical disease which has 100% mortality if it is left unoperated, and that is pretty well known. As you can see on your right side, the diagram shows the compressed left lung, a small intestine, and a very small amount of intrathoracic space as such. The liver is actually herniated up into the chest, which, as most of you know, is a bad sign and a sign of poor outcome in some of these patients. This is what an X-ray actually looks like, but there is more than what meets the eye with the X-ray. As you can see, there is bronchial branching with fewer alveoli and fewer respiratory bronchioles in the Hello? Yeah, sorry. So there is lesser bronchial branching. There are fewer, fewer respiratory bronchioles. Sorry. Sorry about that. Uh, Hello? This, so there is decreased bronchial branching, fewer alveoli. What's important to note is it's not just in the affected lung on the left side. The same condition actually applies to the right side of the normal looking lung as well. So even that lung may appear to be normal, that is still a diseased lung, which is associated with pulmonary hypoplasia, and there is associated left ventricular hypoplasia as well, both of which contribute to lung hypoplasia and the development of pulmonary hypertension. This is what we normally do. In these patients, in the first 24 hours, there is a cartoon on your right-hand side which kind of goes over all the parameters that we actually meet with some of these patients, and this is what you see in CDH patients in the NICU. Standard guidelines require these deliveries to occur in high-risk hospitals. Nasogastric decompression is done at birth, and intubation is done at birth. We obtain vascular access with a umbilical arterial catheter and a right femoral central venous line at the get-go. We perform gentle ventilation with a goal PCO2 of less than 65 and oxygen saturations which are differential with a pre-ductal oxygen saturation greater than acceptable saturation greater than 85% and post-ductal sat which is acceptable greater than 70%. We do not push for more than 70% in the post-ductal patients. Hemodynamic support, our goal is a mean arterial pressure more than 35. We use standard sedation, analgesia, and we avoid paralysis in these patients. All our CDH patients are considered to be ECMO watchers unless there is a pre-designated reason not to put this patient on ECMO as such. This is what an ideal progression should look like. Most of these patients do undergo an open surgical procedure, and there is a diaphragmatic hernia repair, and there is a patch closure. Some people use a silo, some people do not, and do a primary closure. There are few instances of laparoscopic closure as well that have been described, but most of these patients are actually closed by a open reduction. Not all outcomes come out to be the same, unfortunately. CDH outcomes vary, and as you can see on my left-hand side, there is four classes of defects ranging from A to D, depending upon the size. But what's more important is you will see the stage survival in some of these patients is really very different. And as you can see, the stage 1 can have a survival of 99%, whereas stage 4D and stage 5D have a stage survival of 39%. So the question that needs to be asked is, why is there a difference, and how do we actually predict which of these patients can have a poor outcome? So these are the prenatal predictors of poor outcome of congenital diaphragmatic hernia. For the trainees in this group, on my right-hand side, you can actually see how the LHR is to be measured, and that's your lung to the head circumference ratio if it is less than 1. Similarly, an observed to expected LHR intrathoracic liver herniation and a observed to expected MRI-based fetal lung volume less than 25% are all predictors of poor outcome for CDH, which does not mean that they are always going to be associated with death. Can we predict outcomes in the postnatal period? Brindle has provided us a very nice score, good score of which shows, comprises of APGARs, pulmonary hypertension, cardiac anomalies, chromosomal anomalies, and gives you a total CDH score. A high score obviously is a bad sign, but it's associated with poor outcomes. And similarly, the CDH study group, CDH-SG, survival probability, has given a complex diagram to be able to predict which way the outcomes may actually go. But the question that begs to be asked is, why are some of these patients not have poor outcomes? And the factors that are associated are primarily related to the cardiopulmonary function. The diaphragmatic size defect, the bowel and other organs in the thorax, especially the presence of liver in the thorax, degree of pulmonary hypoplasia, pulmonary hypertension, and left ventricular dysfunction, all of which come together and result in very severe ventricular dysfunction and pulmonary hypertension. As you can see out here, the lung is hypoplastic and it's associated with pulmonary hypertension. There is reduced pulmonary oxygenation, and as a result of which there is some degree of hypoxia, which propagates pulmonary hypertension even further. Management of these patients is associated with standard management with conventional mechanical ventilation, which is always what we start with, and we go ahead and rescue them with high-frequency oscillation. We use inhaled nitric oxide sparingly, but if there is pulmonary hypertension, we are actually part of an NIH study which is looking into the role of nitric oxide in diaphragmatic hernia. We also use inhaled iloprost in certain situations. For ventricular dysfunction management, we prefer to use epinephrine and milrinone. We do not use dopamine as far as possible, and we use PGE1 to keep the PDA open as a pop-off mechanism. We treat left ventricular dysfunction again with milrinone, and our goal is to provide adequate coronary perfusion. We do not routinely use surfactant unless the patient is below 35 weeks of gestational age, but even that is a rarity. When everything fails, we are prepared to go for ECMO, and we will just go through that process. This is a cartoon which depicts the pathophysiological progression of the process of how some of these patients are born. At birth, you hear about the typical honeymoon period in some of these patients where they seemingly do okay, but in fact what's happening is there is a degree of left ventricular hypoplasia and pulmonary hypertension which is actually accruing, and this leads eventually to the pulmonary hypertension, ventricular dysfunction, and when everything else fails, we do consider putting these patients on ECMO. So just a quick breakout here, and the question is, can we actually predict which of these patients would go onto ECMO? And this is a very nice tool that was developed at our center known as the mobile.nicutools.org, which includes the 1-minute APGAR, 5-minute APGAR, highest PCO2 on day 1 and lowest PCO2 on day 1. And if you were to actually put these together and just put the numbers, just plug in these numbers, it gives you an 82% probability of having this patient go on ECMO. So when you have a baby that comes to your ICU, you can potentially predict in the first day what is the probability that a patient may actually require ECMO. So coming to the actual CDH ECMO situation, CDH ECMO was first performed by German in 1977. They had a 25% survival, 1 in 4 survived. It is perhaps the most complex indication for ECMO in neonates. 30% of neonates with CDH do require ECMO, and this is part of our ELSO registry. The CDH management among centers is variable, and as a result of this, the outcomes are similarly variable as well. High volume centers, defined as those that do more than 10 ECMOs for CDH, have fewer complications and much better outcomes. Not to say that low volume centers don't have good outcomes, but typically it's the high volume centers that actually do make a difference. What is our institutional criteria for putting patients on CDH? They're listed out here. I won't go through all of them, but the indications and the criteria need to be present in these patients for at least 3 hours, which essentially tells us that we have done maximal medical management in these patients. And they could include hypoxia, it could be because of hypercapnia, because of hypotension, because of lactic acidosis. The one formula that I would remind or request everyone to kind of pay close attention to is the oxygenation index. Oxygenation index, or OI, is your mean airway pressure multiplied by the FiO2 divided by the PaO2. And a higher number is obviously a bad sign. So if your oxygenation index is more than 40, that is an automatic indication to put the patient on ECMO in our institution. Why do we prefer VA ECMO over VV ECMO? You can consider both. There is literature to support using VV and VA ECMO, but we prefer to do this because of the hemodynamic support that is offered with a ventricular dysfunction. We find that venous flow restriction gets minimized if you are on VA ECMO. We use fewer inotropes, so the risk of neck is reduced, and there is assured patient stability during the CDH repair in these patients. This is our list of contraindications. We don't put all patients on ECMO, and certainly there are certain criteria that we don't, certain conditions where we do not pursue ECMO, and those children will go the palliative route. We do not operate on anyone less than 2.5 kilos, less than 35 weeks. If it's a parental decision, if it's referred to us after 14 days, if there is DIC, Fryns syndrome, pentology of Cantrell, or if there are bilateral defects. How do we cannulate? We offer, as I said, only VA ECMO for CDH patients. All our CDH patients actually have their vessels ultrasounded before even at birth or immediately after they are born, just so that we get a sense as to what size cannula they would be able to take. We prefer to use an 8 French arterial and an 8 French venous cannula. The one thing that we have found is that the venous anatomy is very tricky, especially on the right side. But even on the left side, when you put your cannula, the tip may actually enter into the ectatic azygous vein. We use these kind of ECMO cannula that I mentioned to you about. They are 8 French cannula. So this is X-ray on baseline day 1 and immediate post-decannulation, where we put the patient on ECMO by day 2. As you can see, there is complete whiteout on the lungs, both on the right and on the left side. Essentially, with ECMO, we unload the heart and we provide ventricular function and support, and we provide respiratory relief because for the level of hypoxia. Going through the whole VA ECMO portion is beyond the scope of this talk. When do we repair our CDH patients? The literature supports early repair, 73% survival, versus late repair, which has a 50% survival. At our institution, we perform early repair on ECMO at bedside in our ICU within the first 72 hours, and generally within 1 day post-cannulation. And the advantages are quite clear in our mind. It gives you room for gentle lung expansion, mediastinal normalization, and also gives you time for recovery from the pulmonary hypertension. This is how we do our perioperative management. We keep our platelets up. We use Amicar in these patients. We always use bivalirudin in these patients, not heparin. Our intraoperative management is really minimal posterior rim dissection, liberal cautery utilization, patch closure only, and we use a silo in all our patients just so that we do quick surgery and we come out. Postoperative management is by replacing FFP and platelets. This is how the X-ray looks immediately after the repair on day 3 and a patch closure that is done on ECMO. We continue our routine management of these patients on ECMO with gentle ventilation using an open lung strategy. Our anticoagulation is again using bivalirudin. There is a 9% bleeding risk. I'm not going to try and minimize that. That is a risk that we have to undertake when you have a patient that's on ECMO. But most of the bleeding can be managed conservatively. Pulmonary hypertension we manage by using IV sildenafil. We continue milrinone in these patients. But the most important thing that I have learned is patience with masterly observation and close attention to detail. Typical runs are between 10 to 14 days, which is when we start weaning off our patients on ECMO, and these are the settings that we use to wean our patients off ECMO with a lower FiO2 and a echo which demonstrates some degree of improvement in pulmonary hypertension. We tend to decannulate whenever the patient is ready, not when it is convenient to us. And as the previous speakers said, our fellows and our trainees are quite capable of decannulating some of these patients as well. Survival remains around 50%. General ECMO runs are 14 to 21 days. The primary determinant of ECMO-specific mortality is duration of the ECMO. At 4 weeks, the survival drops to 10 to 20%. After 5 weeks, it's down to 5%. And there are survivors who will have associated sequelae that are listed out here. So in conclusion, CDH is a big undertaking, and it's perhaps one of the most complex and significant indications for ECMO. Its perinatal care and early decision regarding ECMO candidacy is extremely important and has to be really well thought out. We prefer VA ECMO at our institution. We support early CDH repair on ECMO. We use standard management principles that are listed out here. The duration, as I mentioned, is the determinant of mortality. And even with ECMO, survival is at 50%. But these would be patients who would have died if you had not offered them on ECMO. So with this, I thank the organizers and I thank everyone for this opportunity to speak about ECMO and CDH, and I'm happy to field any questions. Thank you.
Thank you, Samir, for excellent talk. What I would like to know from you is, in your vast experience, how much improvement in the survival with ECMO, wherever you use?
So what I will say is, when we started off 18 years ago, we had maybe a 20% survival. Currently, with all the things that we are doing using a standardized approach, our survival has gone up to 50%, almost 50 to 70%. What I'm showing out here is the 50%, which is the total survival on ECMO. So I would say a 30% increase or improvement in survival compared to where we started off seems to be a pretty good gain in our mind.